Okay, everybody, welcome back to American Safety Programs and Training, chapter review for Chapter 17, Neurologic Emergencies. Now, we ended up taking the first hour talking about strokes. What is a stroke? What causes a stroke? What the signs and symptoms of stroke are? And how do we treat a stroke? But as with all patients who call you, you need to use your situational awareness and your index of suspicion. Those are two things that have been brought up to you guys earlier in the class by your prior instructor. Situational awareness is what's going on around you while you're with the patient. Is there an argument in the next room and all of a sudden someone gets shot with a gun? Is there a potential violence in the general area where you're taking care of the patient? Is the scene safe or is it not? If it's not safe, get out or don't go into it if you realize or you recognize that it's not safe as you arrive on scene. Wait till the police to show up for them to secure the scene for you. Okay? Is there a fire present? Other than just violence, what are some of the other things that could be going on in the area where you're taking care of the patient that could make the scene unsafe for you and the patient and your partner and your bystanders? Is there gasoline or some type of explosive liquid or flammable liquid that's in the area that's leaking that could catch fire and could cause an explosion? Is there an electrical line that's barely hanging on and it's directly over the motor vehicle accident that you're dealing with? Are you on the expressway? And we all know what happens on the expressway. People aren't paying attention, and even to state troopers all the time. They pull behind the car about, 12, 15 feet behind the car, and they still get hit. So that doesn't mean that just because you're an EMT in a ambulance doesn't mean that you're not running a good chance of getting hit too, because there's too many idiots out on the road. They're not paying attention, and they're going to cause an accident, thus killing somebody. And unfortunately, you will most likely be the one that gets killed. So be aware of what's going on around you, whether you're inside or outside, no matter where you are taking care of a patient. Situational awareness. Okay? Index of suspicion. Index of suspicion. You're called to a call for someone complaining of chest pain, or somebody complaining of a severe headache, someone complaining of a possible broken hip or back injury, or their finger hurts, or their leg hurts. You go show up, and the person's complaining of one type of trauma to their body, but could there be something else that's going on? Are you responding to a situation where somebody was knifed where someone was shot with a knife? How long was the knife? Your index of suspicion is you see the injury, you see the opening in the person's skin. Let's say it's in their abdomen. But what else is in the abdomen? How long was the knife? What other things that could be going on besides what you can physically see? What organs in the body are in the area where the knife, where the penetrating trauma occurred? What organs are in that area that can be injured? What do those organs do? Would they bleed severely? Would they bleed slowly? Do they have toxins in them? So that's index of suspicion. Could there be something more going on than what you see? Okay? So, seizures. What the heck are seizures? Well, most of us know that when we think of seizure, we think of the person that's on the floor and they look like they're flopping like a fish. Okay? There's many other different types of seizures as well. A seizure is a type of altered mental status, just like a stroke creates altered mental status. And when you're dispatched, a lot of times they don't know if it's a seizure if they didn't see it happen, or they don't know if it's a stroke. All they know is that my cousin Jim or my work buddy Bob is acting really, really weird. He's talking weird, he's acting weird. Jennifer, my girlfriend, or my sister, she's acting really weird. My mom's acting weird. Something's not right. She's acting really weird. So that's called altered mental status. Someone had a stroke, that creates altered mental status. Someone has low or high blood sugar, that creates altered mental status. Altered mental status is just basically, it's a neurological episode that's caused by a surge of electrical activity in the brain. So it's like all of a sudden the person's brain has a massive electrical storm and it causes them to have a seizure. They could have a major seizure or a minor seizure. A major seizure is when they're on the ground, they're flipping. Like I said, their extremities are flopping all over the place, and it's scary to see that. It really, really is. Sometimes people can hurt themselves. Other ones, it could be a very minor seizure where somebody just stares into outer space, and they're just staring into the air for no reason. That's a very minor seizure. And there's everything in between. Okay? But seizures can be broken down into two separate groups: generalized and partial. Okay, so seizure is a neurological episode caused by a surge of electrical activity in the brain. In the United States, it's estimated that 2 to 3 million people have epilepsy. Okay? Generalized tonic-clonic results from abnormal electrical discharges from large areas of the brain. Usually involves both hemispheres. A hemisphere is the left side and the right side. Left hemisphere, right hemisphere. Characterized by unconsciousness and a generalized severe twitching of all the muscles, lasts several minutes or longer. Okay, that's the tonic-clonic. That's the one where the person's flipping like a fish. Okay, I hate to use that description, but that's the one I think that most people associate with. Okay, a generalized seizure and a partial seizure. A generalized seizure is also known as a tonic-clonic. Okay. You have the grand mal seizure and you have a petit mal seizure. Okay, so remember, two groups of seizures, generalized and partial. A generalized seizure is also known as a tonic-clonic seizure. And out of the generalized seizures, you have two different types. You have the grand mal and you have the petit mal. The grand mal is when the electrical activity occurs in both sides of the brain, and that's when you get the really severe twitching of the extremities. And then the petit mal is when they stare into outer space, or they might have a brief amount of time that they're unconscious. Okay? And then you have the partial seizure, also known as the focal seizure. Okay? That just occurs on one side of the brain. So remember, a generalized seizure, which is also known as a tonic-clonic, has two different types: a grand mal and a petit mal. Grand mal, electrical activity on both sides. Petit mal, same thing. But the grand mal is when there's severe twitching of the body, and the petit mal, they're just staring into space. The partial seizure, also known as a focal, you have electrical activity going on one side of the brain. Okay, now there's two kinds of partial seizures, or two types. One is called a simple, one's called a complex. Okay, the simple focal seizure, or the simple partial seizure, it just basically there's no change in the consciousness of the patient. They have a little bit of numbness, weakness, dizziness, and visual changes. They might have double vision. Things might become blurred, and they might start to smell sweet things, or their tastes suddenly change. Either they can't taste anything, or they're eating something with ketchup, and the ketchup tastes like something completely different. And the other one is called a complex partial seizure, and that's basically the person has altered mental status. They don't interact with the environment that's around them. They'll do some lip smacking, like they'll do rapid eye blinking, and they might have jerking of like an extremity of like an arm. An arm might twitch periodically, or their head might twitch, or a leg might twitch. Okay. So with the partial seizure, one of two, let's go back to generalized tonic-clonic, talked about that. An absent seizure does not involve any change in the motor activity. It's characterized by a brief lapse of consciousness in which the patient seems to stare and not respond. Okay? So that's a grand mal, and that's petit mal. That's your second type of seizure, your partial, otherwise known as your focal seizure. Okay? And you got the simple and the complex. The simple partial seizure, no change in the patient's level of consciousness, may have numbness, weakness, dizziness, visual changes, or unusual smells and tastes, and may cause some twitching or brief paralysis. Then you have the complex partial seizure. Its altered mental status results in abnormal discharges from the temporal lobe of the brain. It's characterized by lip smacking, eye blinking, isolated jerking, and patients may also experience unpleasant smells or visual hallucinations, exhibiting uncontrolled fear, or perform repetitive physical behavior. rocking back and forth or side to side. Okay? An aurora. Okay? An aurora is not the aurora of the colored lights waving through the sky in the atmosphere like you get up in Alaska, on the Alaskan nights. An aurora is something that people or individuals who have a history of seizures, sometimes they can tell one's coming on, and sometimes they will see spots. It'll be a normal day, they'll be in the grocery store, or they'll be at the beach, or they'll be at the dining table, or they'll be on a date, or they're watching TV, or they're going to be doing anything, walking the dog, and all of a sudden they start seeing spots. Or something gets really, really bright, or gets really dark, or they start to smell something, or they get a tingling sensation. Something happens in their body that they notice. And this is usually the body's signal of telling them, okay, a seizure's coming, and it usually happens fairly quickly after they have the aura. Okay, it usually happens within a couple of seconds after they get it. Once they get it, they usually have just enough time to stop what they're doing, sit down, or put themselves in a position that they know they need to put themselves in so they can then have the seizure. Okay? Some people, they might have just enough time where they grab their cell phone and they hit a preset number and it sends their location to somebody, probably a caretaker or usually a family member, letting that person know, I'm about to have a seizure and here I am. And it gives you longitude, latitude, and you can find out where they are. Okay? Pretty scary stuff. Pretty scary stuff. Okay, next. Going the wrong direction. Sorry about that. Okay. I'm going the wrong way again. Yes, I am. I apologize for that. Okay. Then we have something called status epilepticus. Okay. Status epilepticus describes a seizure that continues every few minutes without the patient regaining consciousness, or they may last more than 30 minutes. Okay, seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes. In other words, the seizure that normally will last a couple of minutes is lasting over a half hour. Or the person may have a seizure and then they may not regain consciousness. Okay, when a person has a seizure, the seizure takes place and then the body's completely limp. This state is called the post-stictal state. Post-stictal state. And what that is, it's the body's way of relaxing and trying to wake itself back up after having the seizure. And the best way I can describe this is somebody has a seizure, you see them on the ground, and they might snore. Or they seem really, really limp. And you might say to yourself, oh my God, they're dead. No, they're not dead. Having a seizure is an extremely physical activity. It tenses all the muscles, tendons, ligaments, nerves in the body. And it's basically like if a person has a 3-minute workout, it's a 3-minute seizure, it could be like, it could have the strain on the human body of doing a 45 or an hour workout. It drains that much energy out of the person. So the post-stictal state is when the body is trying to recuperate from having the seizure. And it may seem like the person is trying to come out of a wicked, wicked deep sleep. Okay? Usually the best thing to do at this point is to secure their airway, make sure it's patent, roll them on their left side, and just let them wake up on their own. It may take them a couple of minutes, it may take them 10, 15, 20 minutes, but the majority of the time the patient will wake up. Everybody's different. Okay? So status epilepticus is when a person has multiple seizures without regaining consciousness or the seizure lasts more than 30 minutes. Okay? Post-stictal state, like I said, will normally last about 5 to 30 minutes. And it's just the way for the patient's body to slowly regain consciousness. Okay? Sometimes if a person has signs and symptoms that resemble a stroke, it's called hemopharesis. It's basically, it's just weakening of one side of the body that resembles stroke. Like I said, if a person has a stroke, one of the telltale signs of a person who had a stroke is that one side of their body is very weak. The mouth's drooping, the left hand's not as strong. When they smile, the left side droops. Sometimes the person can be experiencing that, but they didn't actually have a stroke. They're having an episode of hemopharesis. Okay? So, let's see, we got that. Causes. What are some of the causes? Causes of seizure. What causes a seizure? So you know that a seizure is an uncontrolled release of electrical activity in the brain. It's a neurologic episode caused by a certain electricity. That seizure is broken down into two groups. You've got your generalized and your partial. The generalized is known as a tonic-clonic, and you have two different ones of general seizures. You have the grand mal, petit mal. The partial seizure is broken down into a simple and complex seizure. You know what the postictal state is when the person is trying to come out of having a seizure. And you know about status epilepticus is when a person has a seizure that continues every few minutes with or without regaining consciousness, or it lasts more than 30 minutes. Anybody who has a status epilepticus seizure that lasts more than 30 minutes, that don't regain consciousness, they need to be transported to the hospital immediately, because they're in a life threat. They're in a very dangerous situation. So, causes of seizures. Congenital, you were born that way. Structural, it's just the way your body's set up. Something's not right. Metabolic, it's the way that your body's processing. You can have a temperature, which is febrile. Usually, very young children can have what they call a febrile seizure. It's usually when the body's core temperature reaches above 103, 104, 105. It gets so hot that the body just sends itself into a seizure to release energy. When you're cold, your body shakes. That shaking is your body's way of creating energy, because when you move atoms, and when the faster you move atoms, that creates heat and energy. With your body shaking, it's trying to remove the body very quickly, and it's trying to create heat to warm itself up. Okay? And you have a history of epileptic seizures, and most seizures can be controlled with medications. Okay? Common causes of seizures. For epileptic seizures, it's congenital origin. You're born with it. Structural seizures, it can be caused because of a tumor, an infection in the brain, scar tissues from a previous brain injury, a brain injury itself, trauma, and or a stroke. Okay? A stroke is what? A blockage of blood flow through the brain, not allowing for proper perfusion. Metabolic type of seizure, hypoxia, no oxygen or reduced oxygen, abnormal blood chemical values, the pH level in your blood is off, hypoglycemia, low blood sugar for diabetics, poisoning, you took a poison, drug overdose, you took too much of a prescribed and unprescribed drug, and people who have they're going through withdrawal symptoms, being an alcoholic or a habitual drug user, when they stop, they're going to seizures. And then febrile, a sudden high fever. Very popular with young children. Scary as all can be. Okay? So if you take a look at this, some of these, look at this one. Hypoglycemia. Okay? You got hypoglycemia. Where is that? Where's my, okay. Hypoglycemia, abnormal blood chemicals, hypoxia, which is reduced oxygen. Okay? What do those remind you of? Okay? Fever. Structure of the brain could be a tumor, head trauma, it could be from a stroke, metabolic, you know what, all that stuff, chemical, okay. So, what do those things sound like? Remember I told you guys earlier that when all the body systems are working together, it's like a well-tuned race car's engine. Everything in the engine's working fine. Everything in the body's working fine. You're ventilating correctly, taking plenty of oxygen in, you're breathing fine, your heart's working fine, your blood pressure, pulse, respirations, your blood glucose level, everything's fine, your brain's fine, everything's working beautifully. You're a healthy adult, your body's happy, your body's in homeostasis. Whenever your body is not in homeostasis, something's going to happen. You might have a seizure, you might have a stroke, you might have a heart attack, you might go to cardiac arrest, you might have an internal bleed down your abdomen, something. Whenever your body is not in homeostasis, something's going to be going on in the body. Okay? So, you must recognize a possible seizure. Just like with cardiac arrest, early recognition, cardiac arrest or heart attack, early recognition is key. Early recognition, quick treatment, rapid transport to the hospital for definitive care, those three things can equal an awesome outcome for the patient. Okay? You need to recognize when there's a possible seizure or when the seizure is actually occurring, whether the episode differs from the previous ones, if you've ever seen anybody have a seizure before. Identify other problems associated with a seizure. Okay? Other problems. You want to keep the area clear. Okay? If their body is severely twitching, then you want to move furniture, move things so the person's not going to hit it and hurt themselves. You never hold a patient down who's having a seizure. Never hold a patient down. Just let their body do what it wants to do. The reason being is that it is so strong. If you try to hold somebody down, their extremities down, it is very easy for them to shatter a bone because there's so much force. A 90-pound person soaking wet can have the strength of somebody who's 250 pounds because that's the body's reaction when it goes through a seizure. Okay? And when the seizure is completed, when they're done, roll them over on their left side in case they're going to vomit or there's anything in their mouth. It can come out of their mouth. It's not going to block the airway. They're not going to inhale it. Okay? Following. Okay, that's the post-ictal state. Sorry about that. Okay. So that's identifying problems associated with seizure. Post-ictal state. I talked to you about that. Following the seizure, the patient's muscles relax and their breathing becomes labored. Patients may be present with hemiphoresis, lethargy, and confusion. Lethargy just means like really tired. Confusion, like I said, tired. And hemiphoresis, they got a weakening on one side of the body. Doesn't mean that they had a stroke. It could mean that they had it could mean that they just had a stroke. It could also mean that they just had a seizure, whether it's a major or minor seizure. Okay, you don't know that. If the patient condition does not improve, consider other problems such as infection or hypoglycemia. Okay, what I said earlier, some of the reasons for seizures: an infection in the brain, bacteria. Okay. There are two episodes somebody can do. You're going to have syncope and a seizure. You know what a seizure is? A person doesn't faint when they're having a seizure. A fainting is known as syncope, syncope. Okay, and there's lots of reasons that someone could just faint. They're scared, they're surprised, they've got low blood sugar, something else is going on, and they just faint. There's no life threat. They just faint. They just got some news. They just got off the phone with their mom and their father just passed away. And the young lady or the young man were very close to the parent who just passed away. They get a call or they get a letter in the mail saying, "Hey, congratulations, you just won $10 million. And they get so excited. I would too. They just won Publishers Clearinghouse. Ed McMahon's at the front door with that big 5-foot check. And you get $1 million a week for the rest of your life. They're like totally surprised. That can make them faint. Okay. Patient assessment. When you are assessing a patient who has had a stroke or a seizure, you have to assess the patient. Whether it's a medical patient or a trauma patient. Every single time you are dispatched to a call, whether it's an end-of-the-world call, massive heart attack, or a 6-year-old boy or girl who fell off their bike and they scraped their knee and mom's freaking out because mom can't take the sight of blood. Okay? You have to assess every single patient. If you are unable to assess a patient, just like any doctor or nurse, every single person you come into contact with, they come to you for help, you have to assess them. If you cannot assess a patient properly, you will not make a good medical provider. Simple as that. But it is also very simple to assess a patient. You don't have to be a rocket scientist. You can be any Joe Schmo. You can be a guy who changes tires all his life. You can be someone who makes coffee their entire life in Dunkin' Donuts. You can be the guy who picks up trash every day. Okay, you don't have to be a rocket scientist. Any Joe Schmo off the street can assess a patient. But the average Joe Schmo doesn't know how to assess a patient. They don't know what to look for. But you guys do. When you're assessing a patient, what do you do when you assess a patient? What's the first thing you do? You make sure that the scene is safe. You make sure that you got your gloves on, your body substance isolation, also known as PPE, personal protective equipment, right? You're going to determine, is it a mechanism of injury or is it a nature of illness? A mechanism of injury is what? A trauma patient. And NOI, nature of illness, is what? It's a medical patient. Mm-hmm. Determine how many patients do you have. Do you have 1, 2, 3, more? If you have more patients than you can deal with, you and your partner, if you got 3 or more patients, guess what? You technically have a mass casualty situation on your hands. Okay? Do you need additional resources? Okay? Do you need to call for other EMTs? You need to call for police. Okay? Additional resources isn't just EMTs or firefighters or police. What if you are at the front yard of somebody's house and someone's having a heart attack and you smell, and they're really close to the garage door, and you smell natural gas? You come to the conclusion there's a natural gas leak somewhere in that house or something. Something's going on. So who would you call? In addition to police and fire, who would you call? The gas company. What if you're at an MBA and police and fire are already there, and there's an electrical line that came off the telephone pole and it's laying across the top of the car? Would you call the water company? Nope. Would you call the dog officer? Nope. You call the electrical company. That's additional resources. The gas company, the dog officer for a mad dog in somebody's house, they're not going to let you in. It's like 2 pit bulls. And a man, his auto dialer called you. He slipped and fell and he can't get up. I've fallen, I can't get up. I'm in the bathroom. But my 2 pit bulls won't let you in the house. So you call the dog officer to get the dogs under control before you can enter the property. Okay? So those are additional resources. Then you need to consider, if it's a trauma patient, are you going to hold C-spine stabilization? Or is it a medical patient? Do you need to do it or not? Okay? Guess what? Those 5 things, the scene safety BSI, your MOI, your NOI, your number of patients, additional resources, and consider C-spine stabilization, those 5 things, that's your scene size up. Okay? Next one, primary survey. You're going to verbalize your general impression of the patient. What do you see? What do you have? You don't know everything. In fact, you barely know anything. Okay? But what do you have? As soon as you see your patient, are they on the ground? Are they sitting up? Are they standing up? Are they talking? Are they standing at the dining room table gasping for air? Are they on the ground? There's blood all around them. What's your general impression? What's your first impression when you see the patient? Then you're going to determine the patient's level of consciousness by the AVPU, the ALC times 4. Are they aware of person, place, time, and event? That's ALC. Alert, oriented, and conscious. Person, place, time, and event. Person, do they know their first and last name? Place, do they know where they are? Time, do they know what day of the week it is, what month it is? They don't have to know what time of the day it is. Like, it's 9 o'clock in the morning. Is it morning or afternoon or nighttime? Okay? And then circulation. Then check your circulation. Where do you check your circulation at? At the radial pulse. At the radial pulse, what are you touching when you check the radial pulse? You're touching the skin. The skin is the largest organ on the human body. Okay? You're checking the pulse at the radial pulse. You're going to check for skin color, temperature, and condition. Is it cool and clammy on a hot day? Is it really dry and hot on a hot day? Could they be in shock? Could they be dehydrated? You never know. Okay? All this time, as soon as you're done doing your scene size up, and you start doing your primary survey, which is what you just did, the entire time you're going to be looking for life threats. What is a life threat? Lack of breathing or difficulty breathing, or a minor bleed or a major bleed. If it's a major bleed, you've got to stop that bleed. If it's a breathing life threat, then you need to either breathe for the patient or assist them to breathe. If they're breathing sufficiently, what is that? How do you know? The average respiratory rate for a healthy adult is 12 to 20 breaths a minute. Are they breathing less than that? Are they breathing more than that? If they're breathing too slow or too fast, what are you going to do? Are you going to put something in their mouth? Are you going to use an NPA or OPA to secure the airway? Okay. And if you are going to use an OPA or an NPA, how do you put it in? Which one do you lube up with a water-based solvent? Okay. Circulation. You know, the normal circulation represents pulse. You realize that the average pulse for a healthy adult is 60 to 100 beats per minute. Well, what do you do if their pulse is less? What do you do if their pulse is more? Okay. You just finished your primary survey. Now you're going to do your history, your OPQRST, and your sample. OPQRST stands for onset, provocation, quality, radiation, severity, and time. Your sample is going to consist of signs and symptoms, allergies, medications, passport and medical history, last oral intake, and events leading up to the situation. Okay. Altered mental status. Aside from the stroke and seizures, is the most common neurologic emergency. We need to know what type of altered mental status they have, what caused it. If you can figure out what caused altered mental status, then you can have a good chance of correcting the altered mental status by addressing the issue that caused it. Okay, hypoglycemia, someone with low blood sugar. They're going to be lethargic. They're going to be out of it. Okay, they're going to be acting really, really weird, like they're drunk. Okay, well, they have altered mental status, but the altered mental status was brought on because of the hypoglycemia. So how do you fix hypoglycemia? You give them some sugar. Okay, the body doesn't have enough fuel. They don't have enough glucose. Okay, so you need to find out what the cause is, what caused the altered mental status. Some of the causes of altered mental status: hypoglycemia. Okay, patients can have signs and symptoms that mimic stroke-like seizures. Delirium. It's a symptom, not a disease. Presents on a new complaint. It's a temporary state with often a physical or mental cause. It can be reversed with proper treatment. Other causes of altered mental status is an unrecognized head injury, severe intoxication with alcohol, drank too much, took too many drugs, you overdosed, psychological disorders, medication complications. It could be that you took too much of a medicine. It could be that you just started taking a new medicine your doctor gave you, and that medicine is having a bad reaction with another medicine that you're currently taking. And it could also be infections, particularly those involving brain or the bloodstream. What type of infection could cause altered mental status with the brain that's very common with college students? Think about it. An infection of the brain and the meninges. Now, the meninges is a protective sac that surrounds the brain and the spinal column. When this infection, bacteria or virus, gets into that meninges, it infects it, and it causes acute severe headache, discomfort. Person can barely move their head, and if not identified and treated within a day or two, they can die within 2 to 3 days. Okay? Meningitis. Meningitis is an infection of the meninges of the brain and the spinal column. Remember that. Meningitis is an infection of the meninges of the brain and spinal column. And the meninges is a protective coating that surrounds the brain and the spinal column. And it's very common for college students to get that. So, one of the tall tale signs, if you get dispatched to local college for altered mental status, and you're talking to the patient, and they can barely talk because the head pain is so severe, you think they might be having a really bad migraine, but they have no history of migraines. One way to find it is, can you turn your head to the left and to the right? And they say, okay, and they move it not even a 1/16 of an inch, and they scream out in pain. Another good way is to do me a favor, have your chin touch your chest. Just bend your head down and touch your chest. All of you do that in class right now. Just bend your head down and have your chin touch your chest. People who have meningitis can't even do that. They can't even put their head down, not even a 16th of an inch, without experiencing severe pain. So, patient assessment, like I said, you're going to do a scene size up, which are those 5 things. You're going to do your scene safety, and your BSI is 1, your MOI or NOI is 2, number of patients is 3, additional resources, consider those. That's number 4, and 5, C-spine, consider C-spine. Okay? All patients with an altered mental status should receive high flow oxygen. So, if you give them high flow oxygen, what device are you going to use? Are you going to use a nasal cannula or are you going to use a non-rebreather? A nasal cannula, what's the liter flow? Okay? Is that 2 to 8, 1 to 4? What's the flow? Is that high, low, or medium? What's the oxygen saturation? Okay, is it 24 to 40% oxygen? What if you want to give them a non-rebreather? How do you fill up the bag with a non-rebreather? Okay, what's the liter flow? 10 to 15 liters per minute. That's high flow, and the oxygen saturation is 80 to 90%. Okay, hyperventilation may have several negative consequences. Okay, you do not want the patient to hyperventilate. You don't want them to breathe too fast. Okay, because that could make the situation worse. Just tell the patient, give them some oxygen, and have them try to concentrate on your voice, and just have them take slow, deep breaths. Have them concentrate on their breathing, and they'll naturally try to slow it down. You're going to do your history taking. Okay? Well, not before you do your primary. Yeah, I just said the primary assessment. Okay? Level of consciousness, airway, breathing, circulation. After you're done doing the circulation, the last thing in the primary assessment is patient transport decision. Is this an urgent where we need to scoop and screw? Or is this a stay and play where I can take a few extra minutes just talking to the patient, getting a better idea? Or if I need to get this patient on the stretcher right away and start transport to the hospital immediately. Okay? After you're done with your primary assessment, you're going to take your history. And your history taking is, as I said, OPQRST and sample. Onset, provocation, quality, radiation, severity, and time. And then the sample are signs and symptoms, allergies, medications, passport, medical history, last oral intake, and events leading up to. So, onset. Did it come on quickly or slowly? Did it start how did it start? Okay. Provocation. Does anything make it feel better or make it worse? Q. Quality. Describe the pain to me. Is it sharp, stabbing, squeezing, crushing, throbbing? Describe the pain. Don't give the patient those options. Let them describe it to you in their own words. Okay? Radiation. Does the discomfort, pain go anywhere else? If they're having any discomfort or pain. Severity. On a scale of 1 to 10, 0 being no pain and 10 being the most pain you've ever experienced in your life, how would you rate it? And then T for time. When did it start? I know, Mr. Johnson, you said it started really slow, but when did it start? Oh, it started last night? Around what time last night? Around dinner time? Or what time do you normally have dinner? Around 5:30? Okay. So the pain started last night around 5:30 and it came on very slowly, correct? And he says yes. Okay, great. Because you know that your onset, it came on slowly, and your T for time, it started last night around dinner time, around 5:30. So for your sample, signs and symptoms. What's a sign? What's a symptom? A sign is something that you see. A symptom is something the patient tells you. A for allergies. Do they have any allergies to medications, whether prescription or over the counter? Do they have any food allergies? Do they have any allergies to the environment? What if they go to multiple doctors? One doctor prescribes a new medication. They start taking that medication, and later that day or the next day or the next day afterwards, they start having a bad reaction to the medication mixing in their system. Some medication, when they don't interact very nicely with other drugs, sometimes the effect is immediate within a couple of hours, or sometimes it may take a couple of days for it to show up. Okay? It could be that they take an over-the-counter herbal remedy that is having the same effect to one of the medications that they're currently taking from one of the doctors that they prescribed them by a prescription. Okay? Food allergies. Do they have, the most common ones? Peanuts, shellfish. Okay. Could it be that they're not feeling very good? They're having chest pain and discomfort because they're having agita. Another name for agita is heartburn. But they don't know it's heartburn. All they know is that they have chest discomfort. And he has a history of having an MI in the past. So the patient's scared. It's probably just having a reaction because the cook who made their sandwich before made a peanut butter and jelly for a little kid and didn't change the gloves that he was wearing after he made the peanut butter and jelly. And he's got just an itty bitty amount of residue of the peanut oil on his gloves, and he got some on the Italian grinding that he just made Mr. Johnson. Okay? Let's see. Passport and medical history. Anything in your medical history in the past that could be affecting what's going on today. Last oral intake. When was the last time you had something to eat? Again, it could be a reaction to something, or you ate bad food. And E for events. What was going on before this happened? Okay? Then you're going to take your vitals. Secondary assessment, vital signs. Well, technically the vital signs are separate. Vital signs are not. Vital signs are after the secondary. Okay, so you're going to take your, So you did your history and you're going to do your secondary assessment. Okay? It says vital signs. Vital signs aren't supposed to be there. Okay? Patients with intracranial bleeding may have increased pressure compressing the brain. If the person fell down and they hit their head against something, they could have a brain bleed, and that's causing additional pressure inside the brain, inside the skull. Okay? Can slow the pulse and cause erratic respirations. Blood pressure is usually high. Changes in the pupil size and reactivity indicate significant bleeding and pressure on the brain. So you're going to check the blood glucose level. Check the BGL. Stroke assessment. You have the Cincinnati pre-stroke scale, the Los Angeles pre-hospital stroke scale, the 3-item strokes severity scale, and the FAST mnemonic and the Glasgow coma scale. You're going to find that we use the first one, the Cincinnati pre-hospital stroke scale, and FAST and Glasgow coma scale. Those are the three things we're going to use the most. I've really never seen anybody use the second one and the third one, the Los Angeles and the 3-item stroke scale. Okay? But let's get back to the secondary assessment. After you do your OPQRC and your sample, you're going to do your secondary assessment. And the secondary assessment is what? There's 8 things you get to choose from for the secondary assessment, right? Those 8 things are going to, basically what you're supposed to do during the secondary assessment is you are supposed to concentrate on the affected body part or body system. You have your choice of the following 8 things. It could be the following 8 body parts or systems. It's going to be either the cardiovascular system is a problem, or the pulmonary system is a problem. It could be the neurological system is the problem, the brain. Pulmonary, the lungs, cardiovascular, the heart. It could be the musculoskeletal system is the problem. It could be the integumentary, which is your skin. It could be your GI system. It could be a psych issue, or psychological or social issues, or it could be reproductive system. So those are the 8. Cardiovascular, pulmonary, neurological, musculoskeletal, integumentary, your GI, reproductive, and social, or psych. Okay? You have to determine which one of those systems the problem is. If the person's complaining of head pain, are you going to worry about their fingers? If the person's complaining about abdominal pain, are you going to worry about what's going on with their nose? No. You're going to concentrate on the affected body part or body system. Okay? After that, then you're going to take your vitals. And what are vitals? The triangle of vitals, just like the fire triangle. In order to have fire, you have to have 3 things. You have to have heat, oxygen, and fuel. Take away any one of those 3 things, and you don't have it. Vitals, blood pressure, pulse, respiration. If you take away one of those 3, you don't have somebody living. You have to have a blood pressure, you have to have a pulse, and you have to have a respiration. What's the normal blood pressure for a healthy adult? 120 over 80, 110 over, 120 over 80, the new one is now 110, 120 over 80, 110 over 70, or like 130 over 90. Well, even though that's high. But the average is 120 over 80. Okay? That so happens to also be the range that you would look for the blood glucose level between 80 and 120. A good BGL on a healthy adult is between 80 and 120. A good blood pressure on somebody is 120 over 80. Okay? Pulse. What's the average pulse of a healthy adult? 60 to 100. If it's too slow, too fast, what's going on? What's causing it? What can you do to help it? Respirations. How many times a minute are they breathing? The average number of respirations for a healthy adult is what? It's 12 to 20. So are they breathing too slow or too fast? Then you're going to reassess your patient. You're going to reassess your patient if they're a stable patient, every 15 minutes, every 5 minutes for an unstable patient. Okay? Cincinnati Pre-Hospital Stroke Scale, you can review that in your book. Facial droop, arm drift, and speech. Okay? Look at the far right-hand side. The normal response is both sides of the face move equally, but an abnormal response is one side of the face does not move as well as the other. Arm drift. They both move together. Over here, the abnormal response on the right-hand side, one arm does not move, or one arm drifts down compared to the other. And speech. In the middle, it says normal response. Patient uses correct words with no slurring. Abnormal response on the right. Patient slurs words, uses inappropriate words, or unable to speak. Okay. You can take a look at the Los Angeles Pre-Hospital Stroke Scale and figure table 17.4 in your book. Same thing with the 3-item stroke severity scale, Glasgow Coma scale. If you look at this, the eye opening, best verbal response, and the best motor response. Eye opening, if spontaneous, it's 4. If there's none, there's 1. So the better the person is, the higher the number. For eye opening, you have 4 possible points. If they have both eyes open, they're responding, it's a 4. Verbal response, if they're able to talk to you like the way I'm talking to you right now, they get a 5. As the speech goes down or deteriorates, it gets a lower number. And best motor response, if you say raise your hands, they raise both of their hands, they're doing what they're told to do, they get a higher number. If for some reason they can't, one arm is lower or their legs or arms are weaker than normal, they get a lower number. With the Glasgow Coma scale, the maximum number you can get is 6 plus 5 is what? 11 plus 4 is 15. The best number you can get is 15. If you get a 15 or 14, you're good. If you get a 3 or 4, you're in bad shape. Okay? For suspected stroke patients, physicians in the ED need to determine whether there is bleeding in the brain or not. They do this by special test. And notify the hospital regarding the last time the patient was known to be without their current signs and symptoms of a stroke. Okay? Read everything else that you need to regarding this chapter, and you guys are ready to rock and roll. You guys take care. You have a good day. Please stay safe out there. If you have any questions, ask your teacher or send them in the form of an email to me, and I'll get back to you. Okay? You guys take care. Please stay safe, and we'll talk to you next time. Bye-bye.